We'll move on to the commissioning items and start with 111 Integrated Urgent Care Transformation Programme. Programme Director, Colin, to come and join us. Katie, did you want to introduce it?
So the really my introduction to this is so as a system in Coastal we are clear that the delivery of joined up, integrated and effective urgent care services is one of our top 3 clinical priorities in terms of delivery. What Colin will be doing is talking about the 111 element and out of hours element of that, and how we look at how we marry working effectively at scale to get the most effective service with the local services in terms of our ability to provide consistency and continuity of care. I think this absolutely needs to be placed in the context of the issues that we have talked about extensively as a governing body about our concerns around 111, the quality of services, and particularly at times of high pressure over winter, over bank holidays, how our current services have really struggled to be able to provide safe, effective services, let alone enable an integrated way of working that really makes the right thing the easiest thing to do for patients and professionals. Colin.
Thank you, Katie. So since this last came to the governing body back in July, NHS England published the national specification for the Integrated Urgent Care Clinical Assessment Service, and that's good because it gives us a number of things in terms of mandatory. The key thing is around bringing 111 out of hours together as one particular commission service. The key thing that will help us with is to do with the handoffs, the data flow, the patient journey really in this particular system. The handoffs between the 2 different services at the moment can make it quite long-winded and quite torturous for the patient to actually get the right kind of advice at the right time. So that's good in terms of actually bringing 2 services together to make sure it functions more effectively. The key things it also suggests is around having clinical contact increased up to 60%. So in the current service of 111, it's about 28.8% is clinical contact. So what we're saying in the new world is that actually we want to increase the number of calls that are then dealt with by a clinician earlier, because the longer it's left and not being dealt with by a clinician, the chances are it's going to end up in a part of the system we don't want the patient necessarily should go to, had that advice been dealt with at the right kind of particular time. So increasing up to 60% will then help. We need to make sure we focus on the kind of key kind of groups, such as obviously dental and pharmacy are key areas we can root out straight away. Actually looking at frail and elderly, under 2s, care homes, making sure we direct people in the right way through the system to the appropriate clinician. We often say it's about GPs, and GPs should have an oversight of the particular system because of the impact that it has on GP. If 58% of all calls are to primary care or diverted towards it. It's also about using other clinicians as well. It's using the pharmacists, the paramedics, the nurses, the dentists, etc. It's about using them to help input into the system. The key thing it does say is about consult and complete. So it's really, rather than saying this is the service you should go to, in some cases it's actually saying this is the advice you should have, therefore to treat it yourself, or actually okay to be at home, or able to do it yourself. So it's looking at a different way of approaching this kind of system. At the moment, 111 is very risk adverse, so it does signpost people to A&E, to GP surgeries, which is where the pressure comes from. It's about trying to stop some of that pressure where appropriate, make sure we get the right kind of advice the right kind of way. We've since then also looked at, we've undertaken a soft market testing. We had a number of providers come and look at the model, understand what we were thinking about in terms of their understanding. They fed back quite usefully on what we were proposing. So for example, some of the things, the decision paper was around contract length. We suggested 3 years with a 1+1 contract length. A number of providers actually said that's not long enough in terms of all the changes that need to happen in urgent care, the developments that need to happen, embedding new technology, getting clinicians into a different kind of mindset, making sure that this clinical assessment service is attractive to the workforce, therefore they would like longer. We looked at what's going on nationally, and we're suggesting it should have a longer contract of 5 years with a 2-year extension. That should help in terms of that kind of investment, that kind of changes that are needed. We've also undertaken a patient survey. So some of you have a booklet in front of you, which is looking at the kind of responses that we've had from patients. We've had about 1,000 responses. We're working with Health Watch for the groups that we haven't heard back from, so make sure we cover all kind of groups. But the key message that gave us was around patients want to be able to ring up, to be diagnosed, where appropriate, booked into the right kind of service for them to be dealt with. They want only clinicians to have access to their patient records. It's not about call handlers having access to information, it's about having the right kind of access at the right time. And it's about making sure that they feel, is this the right thing for me to do next? Should I go to hospital, or am I okay to stay at home? One of the key messages we got from the patient survey. Last time at governing body, we talked about direct booking and about GP surgeries, especially with a particular issue that came up. We've gone back to NHS England to say what's within the gift. Under the GMS contract, 111 cannot force direct bookings onto GP surgeries. And actually, we need to look about how that's commissioned across the patch as well. Out of hours basis, urgent treatment centres, we believe that can be done through 111 direct booking. The volume in hours is very small, so therefore we need to look at where the gaps are. In urgent treatment centres 24/7, we should make best use of the current resources, but understanding where the gaps are across the country, or county at least, to know where's the most appropriate place to send patients in terms of direct booking. In the new model, we should expect to see even less people being referred directly into appointments, because those clinicians should be doing the role in terms of actually saying, this is okay, you don't need to go and see anyone else at the moment. So therefore, in hours at the moment, it works out to be about 260 appointments per surgery per year. So the volume is quite small. Our main bulk is actually the out of hours, which is 75%. As part of our lessons learnt as well, was one of the things we raised at this governing body last time. So at the back of my report, there's a lessons learnt appendix about the lessons learnt from other big procurements, and here's what we're doing. So some of those key things are around engagement, around governance. So it's part of the governance decision. We're going through all 7 governing bodies from CCG's point of view across Sussex. We also make sure we've got engagement events. We're also looking at how we make sure we reach all accountable officers from provider trusts, or the CCGs, as well as the local authority, to make sure we're engaging with them appropriately. We're looking at making sure we've got further events coming up in terms of explaining what the model is and how it connects up. That's going to be quite key in terms of making sure everyone understands how this kind of comes together. The clinical assessment service, the part that I will be doing, is only part of this particular model. We're looking at how other components then fit in. So for example, extended access, urgent treatment centres are obviously going to play a part, but we need to know what part they play and how do we then integrate. An out of hours base at the moment turns on at about 6:30. With extended access, those out of hours bases probably won't be needed till 8 or 10 o'clock across Sussex. So I'm bringing together all the urgent and primary care leads to explain their offer in terms of this component, so we understand where the bits need to be switched on and switched off appropriately. In fact, using the best resources in the right place at the right time, making sure it's integrated with the rest of urgent care. I've touched upon about contract length. Also, the other thing is that came out of the soft market testing was around the procurement approach. So for those of you interested in procurement, it's going to be called a PQQ ITT route. That's a pre-qualification questionnaire, an invitation to tender route. That's a standard, straightforward kind of approach to procurement. We thought about competitive dialogue. This is where you have discussions with providers. It makes it more richer in the long run, but it's also quite resource intensive. At that point, we didn't have the specification nationally. Now we have that, that makes the conversations more straightforward in that aspect. We need to concentrate more in the procurement around the quality aspects, making sure whatever provider we put through this whole procurement approach is make sure we're clear about the quality, we understand the impact, they understand what they bring in terms of this new service. Because of the approach, that leads to our timetable. So we'll be pushing the button for this procurement in January, so that's when it starts because of the adverts. We're doing a soft market testing event in November as a follow-up on the previous one, so we can say these are the decisions that are taken at the governing body, so providers are clear about some of the things that are happening. And then from January to approximately April, we'll be then going through what's called the PQQ phase. I'll then be looking at coming back to all governing bodies as part of a part 2, around April time or thereabouts, depending on timetables, etc., just to give an update about where we are, to raise any concerns we may have as part of that procurement, if needed, can be raised. Then we go through to the next phase of procurement, ITTT, invitation to tender, and then we're looking at ratifying the contract after evaluation, end of July, beginning of August, where I'll come back to all governing bodies again to ratify the decisions that we've made as part of that procurement process. We then start mobilising August, September to go live 1st of April 2019. Other aspects we need to be careful of is about that phasing, because I know we'll go live with a new service on the 1st of April. What are the phases that we're looking at in terms of that go live? What happens 6 months in? What happens a year in? Etc. So it's being clear about that phasing. We need to plan that out accordingly. We know lots of procurements. If it's a big bang, there's a lot of pressure there. We accept that there will be a large bang. Actually, it's about making sure we're clear about the sort of next steps. The key other issues that we're looking at is also about workforce. Workforce is going to be so key to this. How do we make this attractive? So we're working with NHS EE to make sure we're getting the kind of the workforce blueprint, understanding about the kind of issues that clinicians face about working out of hours. So for example, around indemnity insurance, it's got a factor that puts GPs off as part of out of hours. So how can we do it as part of Crown indemnity? How can that provider come with that insurance to make sure those GPs are covered? So look at how we can develop it, and also enabling kind of virtual connections. So those GPs, those clinicians can connect to that clinical assessment service remotely, all the kit they need from a telephony, from a technical point of view, and can work where it's most appropriate. The last thing is then, so I've got on the timetable, financial modelling. I put a clause in the governing body paper to delegate some decisions. That's around the fact, because I've got 7 governing bodies to get through, I don't want to get to number 7 and realise I've got to go back through all governing bodies to make decisions. So the 2 decisions I'm kind of seeking that need to be delegated or thought about is around contract length. One governing body suggested about looking at a longer contract length. I'm not totally convinced at this stage, but I need to take that away just to think about it. From my point of view, I think 5 with a 2-year extension is probably long enough, but I want to make sure I can at least look at that and have that delegated down to accountable officers to look at that as an option. The second thing is around finances. We looked at the financial modelling, and it comes within the budget of the current 1-1 out of hours world. Hopefully a little bit less by bringing these 2 providers together. So we're looking at, do we keep some of that money back to incentivise the provider or invest? But also we need to look about how does extended access paid for in terms of that kind of crossover. So again, that's looking at having that delegated down to accountable officers to say how that should be sliced. The key thing from a governing body point of view is we need to make sure it stays within that budget envelope. That's the key thing, just to make you aware of all the things. So I know I'll rattle through everything very quickly. Does that cover off the paper?
Colin, thank you. Question, Jan.
Thank you, Colin. And I know you brought this paper to the Public Engagement Committee, and certainly our members found it really, really useful to talk it over. Firstly, on the front sheet, which is on page 144, it says no obvious impact on equality and diversity identified. And I think there's quite a significant impact, so I think that needs to be amended.
Okay.
I know you have done an equality impact assessment, so I think it would be quite useful to at least refer to that. The other point was that in the survey, the 111 survey that was carried out, and you had about 1,000 responses back, I think what clearly emerged was there were some gaps within that, particularly around elderly, BME communities, children, young people, families, mental health. So, and I understand those are the gaps which are going to be picked up within Health Watch.
Yes.
So I think it's important that somewhere within the document there's reference to that, because most people will think, those are the people who use the service, so clearly that's captured within that could be useful. And I think the only other point I'd make is some reference around piloting, particularly new technology and all that, because that's where the previous contract on patient transport really fell short, and so that'd be quite useful to refer to that.
Thank you. Yeah.
Thank you.
Jenny.
Yes, several points. I hope that's okay. And the first, Colin, then please. I don't know your background, so
That's okay.
the first question is a learning from the PTS and other contracts. Is to what extent do we have somebody who's batting on our side, who really knows the business, who really clinically, both clinician and managerially and technologically understands what's possible, because we have, if you like, found after an event before that we didn't have that right expertise. So that's the first question.
Okay, so in terms of, definitely in terms of that knowledge, so my background very much is project management, program management, has been for the last 20 years across a whole spectrum of different areas. So that helps, and I've delivered a number of procurements before, so that's one aspect. The other aspect is around that clinical input. Yes, we do need to look at how we make sure we've got the clinical governance sorted out, so we're making sure we've got the right kind of clinical inputs. I've got an interim arrangement at the moment between now and Christmas. We're looking at advertising to get a more of a longer term clinical input. So we're looking at Vicky Beattie from Coastal to help input into our model and into our thinking, make sure we're clear. The technology aspect is one area that does worry me at the moment. As area I'm taking to the STP Digital Steering Group. We have a gap. So we did have someone called Wilson Sharp who worked here to help with understanding the technical aspects, a technical solution. And obviously as part of that procurement, we need to make sure whatever the providers say is going to be compatible, works with us, all that type of stuff. So we're now looking about how then do we resource that particular gap that we now have in our programme. So that's going to be taken next week to the digital steering group. To
Okay,
actually
so
say,
maybe that's two issues that we just need to flag in the minutes that we want reassurance on as we go through it.
Okay.
And the technology side, having seen some of the apps that are available now, you know, has moved on hugely since the algorithms were first invented.
Yeah.
The second side, and forgive me because I've got several questions, the second side is about the whole complexity of the system. And what I didn't see in the paper was any plan about patient education. Because once we've agreed what the system is, you know, do they go to their GP, what are the GP hours? It almost feels to me like each local community network, and we've beautifully now designed those, will need to have a kind of instructions for patients. You know, who do they call, when, how? Because patients are clearly saying they don't just want to use 111, they want to use local access. But I think for a lot of patients that's very complex. So I was hoping that that might be featured here. Clearly you've reflected what the patients are saying, but you haven't necessarily said what we're going to do.
And also it's a regular agenda item on public engagement.
So this whole education thing I'd really like to see fleshed out.
Thank you. Yeah, okay. I think, right.
Third thing is the kind of contracting model. And, you know, again, having had our fingers burnt up till now, I'm very worried that the providers are clearly indicating they're a bit unhappy about the contract length. And whether actually we're going to need a more sustainable, longer-term kind of procurement approach. And to me, what that implies is some kind of collaborative public-private partnership which has serious long-term commitment through a public sector partner with the kind of short-term innovation and technological kind of wow factor that comes from private sector maybe. And I'm just wondering whether we ought to be inviting those kind of proposals, because I think if you just go for one of the other sectors, you're not going to get that partnership model, which either has a very short term, you know, can get in and get out quickly and you lose the investment and so on. So I'm just wondering about that. And that really ties into my final point, which is about penalties. And again, it says here about a break clause.
Yeah.
You know, but we're talking about significant investment in either, you know, sites, revision, technological estates. So again, we need to think about how that break clause is going to work for both sides, because the traditional break clause, to be honest, hasn't done it for us before. You know, we've had problems getting out of contracts, no penalties when there has been fault on one side, and the NHS taking the risk. So those comments rather than questions.
Thank you.
I wonder if that could be.
Definitely in terms of the penalties part, I think that's something we should build into the contract. Make sure I go through the right kind of legal advice, make sure we've got the right kind of developments of that contract. So it's not necessarily just about having a break clause, everyone kind of separates actually what the steps we need to take before we get to that break clause, so what the penalties, etc.
Well, I think the paper doesn't spell out the balance of risk. And before, with PTS, I think it's public knowledge, you know, we ended up taking a lot of financial risk because they're fairly the private sector providers.
Yeah.
And in terms of the public-private partnership model?
It's something that didn't really come out of soft market testing back in July. I mean, it's something we could perhaps raise again but in November, but I think it's having that, it's so complex and it needs sometimes a lot more investment. It's kind of my kind of gut feel, but Katie, no,
and obviously the public, you know, we've got GPs here who will know the...
Yeah, Katie might respond.
I'm happy to take Chris's points first, if that's helpful, because I mean, I think, Colin, in fairness, I don't think that soft market testing and the providers would come up with a public-private provider partnership unless it was actually actively put to them and worked through.
I think that's my point.
And so I think Jenny makes a really fair point, because I think if we look at, not just in Sussex, but nationally, and not just for the NHS, but for local government, the track record of successful procurement is really, really low. And I think from a process point of view, you are putting in all the right checks and balances, but I think with the experience that we've had, I think it is absolutely fair and right that we still have a high degree of anxiety about our ability to do this successfully, and I do think we need to explore some of the different options, you know, because we have got some time until January to just make sure that, you know, there's a strong national direction of travel, but I think getting it right is really key. I wanted to make another point, which, you know, Colin, you and I have had this conversation, but you said that you were working to make sure that there may be some savings, but that it was within the cost envelope. I think we have to own as a governing body that if we want high quality services in terms of 111 that stop us from spending money in the most expensive part of the sector, the acute sector, that we need to invest properly to deliver it. So I'm just going to personally put for the record, I do not want to see any savings in this contract, and I would be incredibly worried if I saw any savings in this contract that weren't otherwise used to incentivise the providers, and that I would welcome an approach that said, in fact, we may want to spend more money on this part, certainly in terms of the whole urgent care front door services, that will in fact save the system money in the longer run, because I think we just need to avoid a salami slicing approach, because this is a pivotal part of the service to get right, and to do that it needs to have to be properly invested in.
Chris and Alex.
Okay. Colin, congratulations on Programme Director for the biggest project, most complex, high-impact project we're probably going to have.
No pressure. Yeah, thank you.
No pressure. But I think Katie is right. This thing has the wherewithal to change how we route patients towards our services, how we meet their expectations for service delivery. And I think it's a really challenging time frame that you're going to be addressing to get us to the end point. Three things came to my mind. I know you've got the lessons learned, but one thing we got very wrong in previous out-of-hour contracts, in the PTS contract, was the volume forecast for activity on which the providers base their proposal.
Mm-hmm.
So one thing I'd be looking for as you come back to us is how on earth have we validated, verified, tested the financial model? I just don't think we've got it right in the past, and that's caused us huge problems.
Okay, so do we answer the first bit first? So in terms of the financial modelling, so we use an organisation called Primary Care Foundation, which is kind of NHS England approved, been used across a lot of different areas across.
Did we use them for PTS?
Don't think we did actually. So they're
Okay.
very much in urgent care.
You don't need to tell me that. What I'm saying is, as you come back with it,
Yeah,
that's the
it.
things I'll be trying to test.
Thank you.
There is reference to the mobilisation plan, which is great. I will ask to see the change management plan, and that is not the mobilisation plan.
No.
And again, there was no real change management plan, I don't think, behind PTS. We struggled when we did the One Team, One Call implementation for similar reasons, and I think change management is something I just have not seen really addressed in any of the NHS projects I've been engaged in. So I'll be asking to see that. And then the biggest challenge I think with out of hours recently has been workforce. And when I see a statement that NHSE have been looking at the indemnity issue for some time with no sign of resolution, what can we do, what can the 7 CCGs do to help you to get that resolved, because that appears to me to be utterly fundamental to this. And so if there's something you need people to be doing, writing, shouting, phoning, we need to know.
Okay, thank you. I'll find out.
Alex.
And indemnity also for paramedic staff particularly. As a health director for a rural area, I think the out-of-hours service for rural areas can sometimes be less good because of the issue of rurality. So I'm anxious in the distances from base that there might be in the rural area north of the Downs for the out-of-hours, and the staffing for any visits that are required in such rural areas. Certainly I feel that those waits for visits are much too long locally at the moment. So I'm just keen that the issue of rurality is considered. It's a difficult issue because I think costs are greater to cover it properly.
Ray.
I had a little checklist that you need, most of it being covered, but I would put GP conflict of interest. I know you will look at it, but it will be a central thing, both in the procurement and the delivery. know direct booking is an issue and will be an issue, and you've mentioned it, and that will need bottoming out for the thing. The fourth is training. The built into the budget is the budget for the training to make the service sustainable, and that's tended to slip by in other programs. And the last is what happened with MSK, is having gone through the whole process, somebody who didn't get the contract called foul. And so I would very much wish you to look at the what-if scenarios as to who ends up with the contract and who then has the power of attorney to skewer the whole thing. Thank you.
Thank you. Okay. Thank you, Colin, for the update. I think most of what we said here are things we just want to see as we go through the process. So, with that in mind, we're asked to note updates on 3 things and make 5 decisions, which I won't read out unless anybody has any issues with any of them. Can I ask us to, Sandy?
Just specifically about workforce, because I know we talked about GP indemnity, but also we talk about nurse recruitment, paramedic recruitment. I know we alluded to health education.
And we can build all of that into Colin's update process. Okay.
A specific
paragraph
on that would be great.
Sorry, we're asked to approve the contract value.
The term?
I think it's the indicative value, and then the idea, because we know it's going to be within the current budget, although except Katie's point about, so I want to sort of,
Which is about 2 million, yeah?
well no, it's about 19 million in total.
19 million.
Yeah. Part of it is
I
around...
read that
yeah,
wrong, I missed out the zero.
Yeah, so that's across the whole of Sussex, but the idea is that I want you as a governing body to say we're mindful that it's going to be at least within the current 111 out of hours budget, then delegated down to accountable officers. I'll just go back through all the governing bodies to say how's it going to be repositioned if need be, what's that incentive kind of volume that needs to be looked at. We're saying it's 2 million based on the financial modelling. Is it really that? And there's also about what about the extended access? How does that play into that budget? But accept Katie's points as well about budget as well. It's about you as a governing body being clear that it's 19 million, but how some of that is apportioned out is going to be the key thing.
Everybody happy with that, or is anyone?
I mean, I find it really, I find it really difficult because this is so integrated. Until we know exactly who's going to be doing what, you know, we may be asking our GP partners to do more as part of our approach to urgent care. We may be asking, you know, some other social care to be doing more. We don't know that yet, so I think it's really difficult to pin down the sum that we want to spend on this till we've got the whole package sorted out. I mean, in many ways, so I think it's very difficult to ask us. I think we need to ask for further clarification as the model develops. I don't think we can really agree there yet. And I take Katie's point entirely. You know, the question is, have we got the level of investment right to deliver better care for patients out of hospital?
I think you need to know that going forward you're not wasting your time. So that you need kind of an indicative range. You want us to tell you, if it comes out within this range, we're not going to cry foul, basically, right? So if you just changed it to, you know, that we were agreeing that the contract may have a value lying within the range 20 to 25 million pounds, I'd be comfortable.
Isn't there a problem with putting that information into the public domain ahead of a procurement?
No, as part of our advert, we would be advertising what our indicative approximate value would be, because anyone who came in at 30, 35 million, for example, we're going, well, that's beyond our budgets anyway, so we want to make sure we are giving them that bit of steer up front. So it's about being clear, but you're not saying exactly how much pence you want to spend.
Yeah.
It's that kind of,
Okay.
you know.
So what is it that we want? I mean, I'd say I'm nervous about making up a number. Just sat here. I mean, I think what I've heard Colin say is that in terms of the delivery of this contract, the current envelope, for want of a better term, seems sufficient to deliver the kind of service we want, providing incentives and all the rest of it. We're asking for Katie to have some flexibility around how that gets deployed across the various things that we might get spent on. I think that can include some license to go beyond the current envelope should there be a return on that investment that we're comfortable with. But that would come back to us at in any point, wouldn't it?
Yeah.
So in terms of the decision for today, it's simply about the confidence to move on with the process that Colin has outlined, and to be able for him to put that indicative figure into the advert, presumably. Now, is everybody happy to proceed on that basis?
Yeah.
Yes.
Okay, thank you very much indeed.
It
Take
also
your
asks about length, sorry, but there are several other things.
Yeah.
It also asks about length,
Yeah.
and I think we're all exhibiting some anxiety that even 5 years for certain partners, so I think we again need some. I think once you've talked to the providers and they come with your offers, it may be that we need to look at that.
Okay.
again.
Yeah.
I think we've been asked to approve the proposed timetable and approach, and I think we've all come up with some things that we'd like to see in writing as part of the approach. The change management plan, the leadership of the procurement that aren't in this paper, and an assessment of the risks around that maybe aren't quite here. So I think there are some things that we're expressing concerns about.
Yeah.
And if
Which,
we just
sorry,
say that
to
we've
be
approved
clear,
it,
yes, was what I caveated the whole thing with at the start. So I said I think there are a number of things where we have said we want to see as we go through the approach that's been outlined, further detail come back and assurance come
Yeah,
back,
yeah.
that those items have been picked up, and we will make sure that that's reflected in the notes. Sandy,
Sorry,
go on.
Kieran, not to
Yeah.
labour the point, but it's probably been covered, but I might have missed it in the paper, Colin, I apologise. But the what conversations are the other CCGs having? Are they being asked the same questions?
Same questions, yeah.
And they're being asked to approve how much? Do you know?
In terms of budget-wise,
Yeah.
so it's the same. So the budget. This budget's the budget for whole of Sussex.
It is for the whole of
Yeah.
Sussex.
Yeah.
Right. And our proportion of that budget
It's
is
about 28.8% of that. What that is mathematically.
and that went to
About
Yeah.
Which just brings into sharp relief my comment about how much we spend on these services and how much we expect of them.
Yeah.
Okay, with those questions answered, with the proviso that we've put a lot on the table in terms of what we want to see as the thing goes forward, is everybody happy to agree the things in front of us? Yes, good. Thank you very much. Thank you, Colin. Katie, Clinically Effective Commissioning.
I think Bryn's going to come and join us. So really this paper follows on from the conversations we had around financial recovery, and it really is a basic requirement of the CCG to make sure that the services we commission and our policies and procedures represent the best evidence of clinical effectiveness, and that we have a robust way to make sure that we are only spending money on services that actually bring and add value to patients, and that we are not spending our precious resources on services of which there is limited evidence of clinical effectiveness. I think that sounds like a very straightforward thing to say. In reality, it can be a much more difficult and nuanced conversation, and is rife with issues around fairness and equity of service delivery. We are very minded about that in terms of a Sussex-wide approach at SDP level, and we have committed both via the SDP CCGs but also via the SDP providers, via the clinical SDP board, to do a piece of work that looks at clinical effectiveness across Sussex, and that means that we, however painful and difficult it is, we have a common approach across the SDP to the way that we deal with clinical effectiveness. That is, we've got 3 tranches of work. The first tranche is to agree common policies. The second tranche is to make sure that there are the processes that make sure those policies are implemented. And the third tranche is, as we talked about previously, to look at accelerated savings, those most difficult decisions about what one prioritises spending precious NHS resource on. What Bryn has outlined in this paper is that the work that we have done, the underpinning work we've done as a CCG to get our existing policies and processes into the best possible position to then allow the Sussex-wide work to take that to the next step. Anything you wanted to add, Bryn, or questions? questions.
I'm happy to summarise everything that we've done briefly. It'll take me a couple of minutes. So, as Katie's outlined already, we're part of the SCP-wide kind of piece of work looking at clinically effective commissioning, and I just thought it was really important for everyone to be aware of the work we've done locally as well, because that kind of led into the discussions at STB level. So, as some of you may be aware, Coastal West Sussex, across Coastal West Sussex, there are some medical procedures that aren't routinely funded, and these are known as low priority procedures. There are also procedures which a person or patient must meet certain clinical eligibility criteria to be able to go forward and have that referral onwardly referred. Up until December 2016, we had very little control over the amount and that were getting passed on to our providers, and also the validity of this process around the procedure with restrictions. So we took this as an opportunity to implement a process which can ensure that only patients who meet relevant criteria are onwardly referred. So this process we implemented was called the prior approval process, which involves a clinical assessment of the patient's referral against criteria that has been predefined using NICE guidance and a clinical evidence base. Only once the clinical eligibility has been met does the CCG onwardly refer for the procedures to be carried out by a provider. Having implemented this process, the CCG, having only a finite funding resource available, realised it would be an ideal opportunity to review the clinical thresholds of some of the procedures and to ensure they're in line with the best available evidence, including other clinical policies. So, which is essentially the NICE guidance and clinical research services, and also reflecting commissioning changes that have happened nationally. In March of this year, as Katie already mentioned, the CCGs across the STP footprint recognised that this is an opportunity for some joint working. And we've been working with them over the past 6 months to develop a low priority procedure and procedures with restriction policy that all CCGs could work towards and provide a consistent approach across the region. Being involved in this work has made us realise really quickly that we're ahead of the curve in comparison to our other CCGs in the STP. And we kind of realised we wanted to maximise the efficiencies that we could make, and therefore decided to push ahead in the areas that we see a considerable amount of activity. This activity was on procedures that needed eligibility criteria to be met. With various enablers in the CCG, including the clinical effectiveness team, planned care and the patient care navigators, this has resulted in quite a substantial amount of unnecessary activity and therefore a reduced financial impact. In summary, since December 2016, we've reduced the spend on procedures with restrictions by about just over 350,000, and we're expecting the financial impact for the year to be in the region of just over £1 million. Obviously, we're continuing to work with colleagues across the STP, where we're sharing work that principally we've done in Coastal as kind of a best practice model across the STP, and hopefully by towards the end of this year, we should have a unified set of policies over a lot of clinical procedures. In summary, is about it.
Thank you. Questions? Jenny?
Yeah, I mean, first I'd be really interested to hear from the GPs how it feels with the new process for their patients, because I have to say this, I'm really pleased that we've got a brief paper. It doesn't feel like patient stories come out of it, and this sounds, on paper, easy to do, and in reality we've got patients who think they need treatments, and maybe the evidence says they don't, but that's hard. So I think there's a bit about managing that, humanity of it that doesn't come through the paper, perhaps. I think the second thing, which is a real issue for me, is that paragraph 6. It makes a very bold statement that says the procedures are ones that will eventually need to be carried out. So in fact what we're doing is just deferring many of them, because the patients will either lose weight and then the procedure, or what individual cases. So I'm just checking that the financial plan does assume that this is a deferred financial commitment, because if patients will eventually need the treatment, then we'll have to pay for it, and that just pushes it to another year. So 2 questions. One is from the GPs, we're really interested to see whether they're feeling it, and 2, how we manage that financial deferment issue.
So the forms are slightly laborious, and for some of the conditions where you're filling them in for, it's the same thing over and over again, but where most of the times in the cases where I've been filling it in, approval has been granted. So it's more the it's more the impact that has on your consultation with the patient to make them be aware of the situation that we're in and the evidence base behind what they're requesting. But yeah, like any form, it's a slight hard thing to have to do.
But the vast majority of patients are getting through.
There's not a vast majority of patients who fall into this.
So it's a small, it's very small.
Did someone to answer the question about the money?
And in my limited experience, these are not deferred particularly. If it's not granted, it's not granted. There may be some cases where with varicose vein surgery, many years later, there may be skin changes and a need for a referral, but often the referral is not needed.
So that paragraph may be a little bit.
I think perhaps, Jenny, in the example you gave of somebody who wasn't eligible because of their BMI, but went on a weight loss programme and then became eligible, I think that what we're showing is best practice, because what we've done is made sure that the patient has then got the best chance of benefiting from the operation and is being dealt with in the most safe way. So,
and I'm not doubting that this is evidence-based and it's best practice. I'm just, concerned that we're perhaps suggesting they're more saving than that.
But it will also be true of people next year. So actually you're moving the whole pipeline back, so the saving is recurring.
I think what's not mentioned here in that paragraph, they would eventually need to be carried, but it may depend on lifestyle and certain changes that need to be done, the consequences, and in some ways that perhaps needs to be addressed in that. Because
I think the wording probably doesn't.
Because the wording almost implies that it's being deferred, but actually that there's some sort of.
I think the focus is on that it should increase the patient's quality of life in that they're becoming more healthier to have that procedure carried out, and therefore the benefits are a shorter recovery time.
Because this gives a negative message rather than
maybe.
Right.
I've been to two of the processes at STP level, both general surgery and orthopaedics, and I would commend you that just quite a large extent Coastal is ahead of the game, and I think I witnessed a watering down of the proposals on an STP-wide level. So just beware that if you're going to adopt something that is acceptable to everybody, it may be less stringent than what you currently have. So that would be, I think, my major concern, apart from very briefly the worry that weight cessation services and weight reduction and smoking cessation services are currently not available and so cannot be referenced in your documentation.
Sorry, Kate.
I did also attend one of the STP sessions, and before I talk about the weight and smoking, I'd say that that obviously the overarching ambition behind this is about fairness. It is also about outcomes, and I think what's most important is whatever changes we do make here, that we beforehand consider the impact and the outcomes. Smoking cessation services are available. We're moving into Stoptober, which is the big national campaign. So if you look at, I can send the website around, but there are over 150 locations in the county where you can get that for free. Weight management also is available via Wellbeing, but I suppose one of the points I was going to make anyway was to link in these pathways with those. Yep. And that's a sort of ongoing awareness job to do.
Thank you. Okay, J.M.
I think that leads perfectly on to how we're going to engage, and we need to engage sensitively with people about, what it is we are doing and the rationale behind it, and the benefits that are likely to have in terms of people's lifestyle and health choices. And I think so there isn't a reference here, but I think somewhere there needs to be there about how it's...
And Jem, I guess I'd like to add that I'm the clinical lead for the Sussex-wide piece of work. And I've only recently taken over that clinical leadership post, and I think the most important thing for me is, although the workshops are helpful in terms of making sure that we have clinical consensus, and they've had lay and patient representation on those workshops. Actually, this is about having an honest conversation with the public now and up front about the difficult conversations that the difficult decisions that we have, and the decisions that we're going to need to make. And I think the public have been really, the representation on the workshops has been really clear to us, is that actually it's probably less about consulting about specific issues and more about the overall communication. So I just wanted to reassure you that I think we know that we haven't done that well yet, and as an SDP, we need to make sure there are consistent messages that are delivered through the local CCG mechanisms, but we're saying the same thing.
Yeah. And I think it was a bit similar to what Brighton did about paracetamol, which is making people aware that, look, you know, over the counter you can get it for whatever, £2, and it's going to cost us CCG £60 if you go through it. And once people recognise that, they understand why the decisions are being made the way they are. And it's that sort of those are the sort of conversations we need to have with our patient and public around that.
Thank you. Anyone else? Okay. Thank you very much. Sorry.
Sorry, just final point about picking up on Rafe's point. Is there a way that we can sort of address those risks to watering down any proposals that may come through and identifying what they might be?
Yeah, so me from Planned Care and Sue Carter, Head of Mental Health Management, and the Head of Clinical Effectiveness are feeding back constantly on the revisions to the policies, and where they become less tighter for us, that's the feedback we give.
Okay.
If the STP Clinically Effective Commissioning Group decide that actually the policies that we've adopted in those areas where it's tighter is more appropriate clinically, then that will be the suggestion across the STP.
And because there's a great deal of work about getting it right first, which is probably the most important.
I mean, if you take the example of the common policies across the STP, originally it began as 19 common policies. That got reduced to 11 because they weren't that common. There was an assumption across the STP they were common. And we're at a point now where I think we've agreed 5 of those 11, and that's essentially because the clinical evidence base that we and others thought wasn't wide enough, and it wasn't taken into account kind of the type of eligibility from other CCGs.
Thank you. Okay, thank you very much indeed for your work on that.